So one of the things we wanted to discuss at this meeting today, so we're really kind of dependent on all of you to contribute as well. We don't want it to just be a didactic sort of lecture series, is really to work out where do we go from here in the patients in whom we've done the best repair we can, we've prevented the infection, they've recovered well physically, and then they come back and tell us, actually, I'm still wet. What shall I do? So my colleague, Dr. Ahmed Sahfan, was going to help with this section. Unfortunately, he couldn't come, so I am presenting on both of our behalves. So we were looking at the role of urodynamics in post-fistula care in particular. And I think it's already been alluded to, the neurological damage that occurs physically just from having a fistula, forget the hole, is so huge and so significant that chances are you're creating a sacral neuropathy. You're also creating usually a neuropathy affecting the limbs, and Jill will talk to us about that later. And I suspect a lot of the patients that we see are not just the physical anatomy disruption, but also the fact that you've disturbed the physiology. So, as we know, the bladder's role is really to store and to void under voluntary control. And in order to do that, we need the integrity of the macroscopic and microscopic anatomy of the bladder, but more importantly, an intact central nervous system and peripheral nervous system. So whereas fistula repair tends to focus on getting the macroscopic bladder back together, very often we have not addressed this area at all. So if you look at the schematic sort of arrangement of the bladder, it's quite a complex structure and it's got multiple points to it. And I think the only reason I'm putting this up is just to clarify to all of us just exactly how important it is that if you get disruption where you've removed a whole chunk of the bladder wall involving all of this complex, you can imagine your communication services across the bladder are not maintained, the protective layers are not maintained, and then of course your neuropathic response is always going to be present because you've disrupted all your neural circuits. And I've put this up, it comes from some of the work I do in neurology of the bladder, that actually without if you need a bladder to work well, you need the intact bladder to send the right messages to the brain. The brain then in the periaqueductal grey matter, which is sensitive to stretch, sends the information to the micturition center, and then in the process, you get that message coming down the spinal tract. Now, I think all three of us have already mentioned that if you've got a fetal head impacting on this part of the body, not only do you destroy this and destroy the delicate balance of communication, but often you've destroyed part of this lower part of the cord as well. And this is just to show you the complexity in relationship to all the areas which need to be present for us to restore continence. So what's the typical symptom complex these patients present with? A lot of them will come with very well-defined stress incontinence. Some will come with frequency, urgency, and nighttime problems. Some of them will come with dysuria, recurrent infections, and pain. And I think it's very important we don't underestimate the role of pain. There is a tendency in the fistula world for people to say to the patient, we fix the hole, so okay, a bit of pain. But actually, pain is so debilitating, and we mustn't forget that. And Chris is absolutely right that in a lot of centers, pain is almost seen as an issue, for the acute post-operative procedure, but after that, we shouldn't worry about it. The role of incomplete emptying, the role of prolapse, which increasingly is becoming an issue. So a lot of hospitals now will tell you we fixed the fistula, but she's got prolapse, don't know how to deal with prolapse, never dealt with prolapse before. Would you agree with me? I can see some heads nodding in the audience. And of course, sexual dysfunction. Now, in theory, if all of the patients present exactly like this, life would be easy in a sense. You could say, yep, she's definitely got stress incontinence. Yep, she's got an overactive bladder. Oh yes, she's got retention. But typically that's what we see. So they might have symptoms of stress incontinence, but actually it might be an overactive bladder. You could have frequency and urgency, but it might be stress incontinence. And it's a real mishmash. The whole thing is very, very complex. And that's why a lot of surgeons in the field are looking for ways to try and work out what is the primary problem? How can we make it better? So the investigations we traditionally use in any urological field is really to rule out the possibility of infection. But we've just heard from Chris, most of these patients are permanently colonized. And it may not be colonized with a bacteria that gives them a big major problem, but they are permanently colonized. So actually taking a sample may be helpful and we may be able to treat it, but it may not resolve the situation. And then with regard to the bladder, working out how well the bladder empties and how well it sustains the storage ability. So we all know about a normal void in females, and this is what sort of patients can typically present with this sort of abdominal straining pattern and difficulty in emptying. And the patient will tell you, I want to pee, but I'm having real difficulty trying to pee. And after struggling like this for a while, and bear in mind, a lot of them are scared to bear down because they're fearful that the surgery you've done may pop open. I know it doesn't fit with the surgical perception, but if you've had a hole for a long time, I have seen women walking gingerly for weeks because they're worried a stitch may come away and the hole will come back. So it is quite traumatizing for these women. So voiding and straining is one of the issues. And then, of course, working out what the post-void residual is. So sometimes these simple things give you a very, very reasonable idea. So if you think it's indicated, you can catheterize or perform an ultrasound scan, and a lot of units now do have little simple scan machines. This is the sort of range people work with, especially if you're dealing with a low pressure situation, but you need to interpret it in light of the clinical situation. And there is a group of thought now and interestingly, there's a document being prepared by the standardization committee looking at the underactive bladder as opposed to overactive, where the retention value shouldn't be a number, but should be a percentage of the full volume. So this is the sort of thing you need, and this is the sort of picture you're looking for, in the hope that you can then at least have an algorithm. So if a patient presents with urgency and frequency, you measure their post-void residual. If it's less than 100 mils and they've still got symptoms, you can still go straight to treatment with some form of anticholinergics. And in the developing world, oxybutynin is still the main drug. If they have a higher residual, and I'm using 100 here, but let's say a residual that's clinically significant, you need to think about catheterization. And in most of these countries, you're looking at a single permanent catheter. And so there are certain catheters that patients have access to, so they don't discard the catheter. They can use the same catheter as long as they learn how to clean it properly. And then you look at whether you can achieve continence with medication. So how does urodynamics work? Well, we all know what a filling phase looks like, and we know the idea is to achieve a good bladder volume and to keep a nice, reasonably straight detrusor pressure line. That's what we'd like to see. We'd like to also see the patient to be able to pass urine beautifully, a little rise in the pressure, but to empty to completion. But in the vast majority of the patients we look after, they often complain of what sounds like urgent incontinence, and they often complain of urgency and frequency and the inability to reach the toilet on time. And you see this actually sometimes even on the ward when you've just removed the catheter, they'll be dropping little drops as they walk. So this is the picture that most of us are hoping will not be the case, but can be the case. But I'm going to show you an interesting paper that was just published last year on this. In my sort of practice, or the cases I've looked after, the vast majority of the patients I looked after have mixed incontinence. They really do not seem to have as specifically well-defined pure stress incontinence or pure urge incontinence. They don't seem to fit the group. They often have a mixed picture, and in ideal circumstances, you'd like urodynamics to confirm that. The other group, which Chris has already alluded to, is the retention group. So the question arises, is it because the outlet is stuck or difficult, or is it because the bladder is not working? Is it related to other conditions? And I think that's a very valid point to say the older patient who suffered a cardiac arrest. We sometimes forget that some of the patients we see would have had fistulas for 30 odd years, but actually we're just seeing them now. So the focal point shouldn't be the fistula, but more about the person in front of you who happens to have a fistula. And then all the other issues that may come into place. Some of them may be on medication, and there are some places which advocate some use of antidepressants. And then, of course, they can present with a combination of symptoms. And I've just put this up because some of them just have a functional or transient problem, and it may be due to one of these issues. So it might be the urinary tract infection we alluded to, the fact that they can't get from the bed to the bathroom or from the chair to the bathroom quick enough. They can have severe constipation, especially if it's the first time in their life they've been put on codeine medication. And then, of course, there can be other issues such as psychological cognitive deficiency and so on. So I thought I'd put this paper up. So I went sort of trawling through the literature. And this is the only paper produced by Judith Go and the team in Addis Ababa Fistula Hospital, looking retrospectively at patients who underwent urodynamic assessments between 2008 and 2009. 154 women, 49% turned out to have urinary stress incontinence, 43% had a mixed picture, 3% only had pure detrusor overactivity, 5% were considered to be normal, and about 7% had a high-ish postvoid residual. So what they thought was that actually, although there was a dictum for a few years to focus on the overactive bladder and the dysfunction of the detrusor because of the retention issue as well as the symptoms, actually the vast majority, it was due to probably impaired urethral function. So the urethra is just, even if it's intact, it's not working as well as it should do with the rest of the bladder's function. And often in a lot of the surgery one does in Africa, the support mechanism of the urethra has gone. So even though you might have an intact urethra, it's sitting much lower down. And again, there is that adage that they say to the patient, well, you've got the hole fixed. But as Chris said, doesn't matter if the hole's fixed. If you're still leaking when you walk or stand up, you're still leaking. So it's quite an upsetting situation. Now, there was another interesting paper, and this is from Pakistan, looking at 157 women whose presenting complaint was stress urinary incontinence, 33 of them with urge incontinence. But actually, when they did urodynamics, it was 37% or almost 38% who had true USI, 24% DO, and this is the reliability level between them. And there was weak agreement only between the clinical findings and the urodynamic assessment. So therefore, in only 78 cases did the urodynamics actually, so 50%, the urodynamic studies matched the clinical findings. So they felt there was a poor level of agreement. So I thought it was extremely important paper in a sense because they were using urodynamics in an under-resourced setting. They were using a slightly different form of a urodynamic machine, and yet they were having great difficulty matching the patient's symptoms with the outcome. So this is probably a lesson for all of us. So urodynamics has a role, but we have to be cautious how much we push it forward in our patients in under-resourced places. Which brings me to the therapies. Well, because we know stress incontinence is associated with pelvic floor damage, and this is just a little picture to show what happens with attrition of your support muscle and the fact that you leak if you put any pressure on the bladder. And I suspect that a lot of our patients with fistula, post-fistula repair, the muscles here have disappeared or are non-existent. And so the poor patient has nothing to support at all the whole urethral complex. And so therefore, it brings me to the continence procedures. So I often go to places and everybody says, oh, we can put in a little tape. Now, all of you who work in the field know full well that these patients are probably very high risk of scarring and problems with lack of blood supply. So in my opinion, I don't think use of tapes is very useful. I have come across a couple of patients who've been operated on by colleagues where they have been given free tapes and they were put in, and almost all of them had erosions through the vagina because they didn't have enough thick vaginal tissue, which comes back to the role of Marsh's fat grafts, and maybe we do have to reinstate them if we're considering this sort of thing. But this is quite a stringent material, and it is not good in an avascular situation, which we often are when we're repairing fistulas. So it brought other things into the fore, so the role of mid-urethral injections, and of course the other role of bladder neck injections, either using autologous fat or using alternative products. And I think the vast majority of people tend to go for the bladder neck injections if you've got enough of a urethral length. There is a role still for the Birch-Kulper suspension if you've got mobility. The only issue is here that to make sure that if you haven't got a hole which is very close to here that's been repaired, particularly this is one of the biggest areas you get tension. And I remember one of the first Birch-Kulper suspensions I did in Addis Ababa Fistula Hospital towards the late 90s. We did about 4 in a morning. All 4 appeared to be successful, but one came back with residual incontinence, and it was this area. The area between here and here was so scarred, and we didn't pick up on the fact that actually when we lifted it up, she actually ended up tearing and it tracked back into the bladder. So we ended up with a new fistula. So it is very important to make sure the mobility is sufficient to maintain the long-term response. Well, what about the overactive bladder? Well, the jury's still out, but I think medication remains the major thing, and in particular oxybutynin, now tolterodine, which is more acceptable in both of them are cheapish, so they're available. There is a role for DDAVP in patients who have a nocturia problem, and I've put cannabis here because some patients with neuropathic bladders have benefited from cannabis medication, but it was only available for a short period of time. But it's just to remind me to mention it because you may see it in some centers. Then the big issue became, what about the role of botulinum toxin? So if you go back to the paper that we saw from Addis, you can see only 3% had proven only got detrusor overactivity. And there is a lot of questions, and this sort of the big picture of incontinence generally is that if you stabilize the urethra or you make the urethra a better and more compliant organ, do you really worry too much about the overactivity, and should it just respond to pharmacotherapy? I know at Addis Ababa Fistula Hospital about 5 years ago, they were going to use botulinum toxin in a proportion of patients. It never seemed to take place, partly because I think there was a slight rejection by some of the patients of the concept. But as you can see, they do need to have repeat injections, and a lot of the patients we look after go back home, and home is many, many hundreds of miles away. The long-term effects are unknown, and I know now there are papers coming out suggesting the use of botulinum toxin long-term may not be as efficacious as we had thought. And then, of course, there's always the risk of performing intermittent self-catheterization. So somebody who has done well and does not have retention, then you're introducing yet another risk factor to their problem. So I put this in because actually, although catheters, I would like to think I'm not a great protagonist, I think it can save people a lot of issues. And there is some merit in looking at the role of long-term catheters or the lipstick catheters, and certain hospitals have access to some fancy designs like this, but the vast majority have access to a plastic single-use catheter, but has been repeatedly used. And there's some nice studies done actually in France, looking at so-called single-use catheters that can be used for almost up to a year without any major problems. So, the belief that a catheter must be used and discarded, actually there's probably not much in that, other than perhaps we have to think whether there are other issues here, maybe commercial or otherwise, but we should be considering that in some of our patients. We have had a few patients where they've now got a continence issue down below, but their retention is so bad and they can't catheterize, particularly if they've got severe flexure injuries and problems like that. And they've benefited from suprapubic catheter insertions changed once every 3 months. But to be perfectly fair, those patients often cannot leave the facility you're working in, or they need to live close by or be involved in the community but close by. So you have to sort of be aware of that, and so you don't offer this as a simple answer. It's as similar as offering a stoma. You need to make a very careful decision about who gets what and when. So really, in conclusion, we need to know more information about the types of incontinence to determine whether we need to use urodynamics, and if so, when. We need to look at different assessment techniques which are affordable and useful in under-resourced settings. And I think this is quite important because, as you know, there are lots of different techniques using bottle pressure measurements and so on, which may be more useful. And then we need to engage fistula surgeons and advocates to look at better assessment pathways. So the whole jury is out on this. I think there is a great belief by a lot of surgeons in the field that urodynamics are mandatory, and it would be lovely to have urodynamics everywhere. But the big question is, do we really need them? And if we need them, do we need them in the format they're in? Because you're using a lot of reusable components which have to be discarded. They cost an awful lot of money. And, the question then arises, under what circumstance should they be done? But I think there is merit in considering centres of excellence, perhaps, and we certainly had a discussion about this in the Fistula Committee at ICS yesterday, whether we should be looking at developing certain centres in every country where this facility is available for selected patients. So it comes back to careful patient selection. But if we find out that actually the vast majority of incontinence involves stress, and we can find another way of detecting that without having to do urodynamics, then maybe we can do something quicker and better for our patients. Thank you very much. So, yes. Yeah.
Thank you very much for the beautiful talk.
Thank you.
You made a very important comment on the use of synthetic slings.
Yes.
With previously operated patients. I would ask you, how then would you manage a patient with de novo or persistent stress urinary incontinence after a successful fistula closure if you're not able to put a sling and you're not able to do a Birch procedure due to a scarred region?
Yes.
And my second question is, there's a controversy that these patients are generally malnourished and they have weak native tissues. So treating de novo prolapse, what is your criteria for using native tissue versus a synthetic mesh?
Okay. So in response to the first question, so I remember in Addis Ababa, the vast majority of our patients, we were using bladder neck injectable techniques, and predominantly at that time using autologous fat from the anterior abdominal wall, which lasted for about a year to a year and a half. Now, at that point, we didn't have good physiotherapy. We didn't have input for the other managements and bladder and particularly fluid control and so on. So that was a thing that came later. And I suspect most of us will still probably stick to that because it's probably the safest option. I think there may be a group where slings may be helpful, but they need to be carefully selected, good vaginal mobility, good thickness to the vagina, and so on, because that is the big issue. A lot of these women have extensive scarring. With regards to the patients who have prolapse, so one of the things we've discovered in the last few years is a lot of the surgeons, general obstetricians and gynecologists, as well as fistula surgeons and urologists, are not as adept at doing prolapse surgery as most of the people I would imagine in this room are. And so actually even native tissue repair techniques were slightly difficult for some of them. So actually improving their knowledge on that was very important. With regards to the mesh, as you know, with the FDA and the MHRA in the UK, there's been a huge backlash against the vaginal prolapse meshes, and I think that's going to be an issue that we have to discuss in the future. But certainly in those group of patients, it's probably not appropriate given the problems that they can have and develop because of the problem with the avascularity of that whole tissue and the thinness. So my view would be if you can undertake native tissue surgery, achieve some reasonable response. The other thing I think we are sort of driving forward is counselling and actually taking and consenting these patients appropriately, giving them an idea about outcome. It seems to be the way forward at this point in time. Maybe in the future something else may be helpful.
Very often the patients are coming in with procedentia, so they're having the uterus well outside the vagina. And there are some reasonable options, I think, in terms of native tissue repair that don't, that you can do a sacrohysteropexy, and the sacrospinous ligament is usually pretty good. I mean, the ones that I did with the gynecologist in Gondar, we never felt like that ligament wasn't good, and it's pretty reliable. And if the uterus is fixed, usually I think your cystocele rectocele repair is not such a big repair then. Similarly, we did, and there is a very small amount of data about using rectus fascia to do an abdominal sacrocolpopexy, or you can even sew the uterus to the sacrum. I mean, it is possible. It'll usually reach S1 or S2. I mean, you can get there and put a stitch in. So I think there are some things that will hold up, at least reasonable, but of course, no long-term data, not even 1 year follow-up on a series or anything that we could really tell. But that would be what I've seen done.
I think having seen, I don't have any pictures with me, they're on my laptop, but I've got some pictures of patients where they used ethibond sutures, which are the braided suture, and they used that to try and repair part of the anterior wall in some way. And of course it all came through, and it created multiple holes and fistulas. So I think the patients with prolapse, exactly as Chris says, if you can adopt or adapt a technique that you have that can give them reasonable support and care, that we know the long-term effects generally are not that great. We know that a third of them will have recurrence of some sort. It's actually probably safer for them in the long run. And then we use a lot of pessaries. A lot of us are now using ring pessaries, but again, you have to be careful because I've had a patient who had a ring put in and then got an avascular necrosis at the base of the ring and ended up with a new fistula right in the pouch of Douglas. So it can, you can help one thing, but you can end up with a complication of another. Sorry,
and I would just add for clarity, in general, these are not the same women. They have the same predisposing factor, but most of the women that have a fistula don't later end up getting prolapse because their pelvis is frozen. I mean, they can, but it's not, what it is the women who had multiple deliveries, difficult deliveries, work in the field, carry, heavy lifting all the time, difficult labor, they have all those risk factors and they get prolapse. So you go to a fistula center and you say, I'm going to fix fistulas, and you got a whole line of women who leak, and that's all they know is they leak, and they leak because their bladders are hanging out and their uterus is hanging out. So
that's a very important point. So at a recent call in Kenya, they put out a call exactly for that. Do you leak when you walk or do anything, So obviously they were looking for fistula patients. Over 2,000 women answered the call and walked physically to Kenyatta Hospital in Nairobi, where actually they ended up finding out that only 17% of them had a true fistula. 17% had a true fistula. The vast majority had prolapse, stress incontinence, and other factors. And then they found some of them had actually been previously repaired elsewhere and now had stress incontinence, but they thought they had recurrence and came in. So out of that group, there was about another 20-odd%. So the vast majority of the women turned out not to have a fistula at all, which then brings me back to the first talk I gave, which is the epidemiology. We are still not certain of the figures. I mean, there was a fear factor many years ago that thousands and millions of women with it. But actually, when you start going in depth into different areas, the numbers are never as big as you assume. They're still big, but they're not as big as you think. Yes, please.
You mentioned in your algorithm regarding urinary frequency and urge incontinence, do you think we should include assessing bladder capacity, similar to like using poor man's urodynamics? Because a significant portion of these women that come back due to residual incontinence have, very small bladder.
Yeah.
And if we do test for bladder capacity, do we still, if a woman has very small capacity, do we still treat her with anticholinergics? What's the role for management in her?
That's a really good question, and you're very right. What do you do with the woman with the small intact bladder? Because it's not functional either, is it? And we've had a sort of a big debate about this a few years ago in Boston, where all the surgeons came together. What do you do with those patients? And there really was at that point, these are bladders that wouldn't expand despite anticholinergic medication. Some people had even tried botulinum toxin in a small proportion of patients. It didn't make absolutely any difference. And actually, from a quality of life perspective, it was thought a stoma would be better. But of course, psychologically accepting a stoma in that setting is a nightmare. So patients were given the option, and that became the dictum. You should tell the patient what the long-term consequences are, that you probably can't fix his bladder. There's going to be a talk later on this afternoon about reconstructive urology and whether we should be looking at doing recon clams in these patients, but you need enough bladder tissue to do it. You can't always do it in the very small little, the little ball of a bladder. So it's a very good question, because I don't think we still have the answer. We're still working on that. We have to work on that as a team. Okay. Well, thank you very much.